Welcome to our first English episode on the Physio Global platform. In this podcast, in collaboration with the Erasmus Medical Center in the Netherlands, we will be hearing from orthopedic surgeon Dr. Duncan Meuffels. He will be giving us a presentation on knee luxations. In this episode, he will be covering the trauma mechanisms, surgical interventions and rehabilitation, as well as an insight to the patient's point of view of the process. So please take a moment and listen to this interesting presentation.
Welcome at this podcast where we're going to talk about knee luxation. I'm an orthopedic surgeon who primarily focuses on sports trauma and on trauma. I work in the Erasmus MC. You saw a picture of that center before, and I take care of a number of professional teams, and I research different knee disabilities, especially in the young patients. And I'm very happy to talk about this very important topic. To start introducing multiligamentous knee injury, it's a dislocation where the tibia is dislocated from the femur and then at least two or more of the ligaments connecting both osseous structures are damaged. It's a rare disease, about 0.02%, but it's a devastating injury. And with this injury, you can also have perineal damage, popliteal nerve or arterial damage, and these patients a lot of them are high-intensity traumas where they have associated injuries. They can occur or present themselves primarily maybe in the A&E department, but they can also come with isolated knee injuries to a general practitioner, to a sports trauma center, or to a physiotherapist. First of all, I think it's important that all of these different disciplines are aware of this, because what I see in my practice is that sometimes it's not recognized, and treating this secondarily makes it really a lot more difficult, and the outcome is less good. So I think it's important not only for orthopedic surgeons, trauma surgeons, first aid physicians, but also for general practitioners and physiotherapists to be aware that this exists. They can come in many different colors, and I show this. This looks very cubic, which we like in Holland, what Mondrian did in the past. But it's a Venn diagram where we can add different kinds of injuries. And what you can see, for instance, in the red bracket where the ACL injury has been put down, if you can combine this with the green, which is the PCL, you can see how many different combinations are possible. And I think it's important to be aware that a knee dislocation can have many different forms and shapes, and you have to treat it accordingly. So when you look at these patients, they can come from more or less three basic trauma differences. I think the majority come from high-energy trauma. These are patients who had car accidents or motorcycle accidents, and what we see more often these days, at least in the Netherlands, are scooter accidents or falls, and this is about 2/3 of the patients that we see. These not only have a knee dislocation, but they also have other injuries, thorax trauma, neurotrauma, which of course we have to treat probably first. Secondary, we see sports-related trauma, where it can be different kinds of injury patterns, hyperextension, hyperflexion, in valgus or in varus. And something that I think we see more often, but it's difficult to compare because we don't have numbers from the past, are low-velocity accidents, and then especially in the morbid obese patients. We see about 6, 7, 8 of these a year, which are a difficult group to treat because of the extra comorbidity. So I think to start or maybe end with the take-home message is be aware, so not only as an orthopedic surgeon, but also as a physiotherapist. Recognize that this is not just a singular ligamentous injury, and this needs to be treated swiftly because it really has a detrimental effect on your outcome. So be knowledgeable, treat accordingly, and this is not just a rupture. I think this is much more for the patient. It's a life-changing event, so try to be aware of that. I'm really happy that many of the hospitals around us in the Netherlands are aware of that, and we're trying to centralize this care, and these are an example of the other hospitals that have referred patients to us, and we have then treated these patients conjointly. So thank you very much for centralizing this. How do these patients come in? We are a tertiary center for academic care. Through WhatsApp, I get an X-ray, and then the treating physician there says, this is not a normal X-ray, help. And I'm really happy that we are able to help for this. It's not only the X-ray, there's also a patient which is around that knee, and sometimes the shape of the knee, especially what I mentioned before, the morbid obese patient or the multi-trauma patients, you're distracted, you don't look at the knee, you don't recognize it. It's sometimes difficult to recognize even that the knee joint is dislocated. But be aware, if a patient has, if they are conscious, and they can tell about the pain they are feeling, and it's a very painful injury, but even then it's sometimes missed. So be suspicious of this multiligamentous knee injury. If a knee hyperextends more than the other knee, be aware. If you see an ecchymosis, or a bleeding on the lateral side or on the medial side, be aware. If maybe the patient has a cold foot, or you see that you can't feel the popliteal artery normally through the dorsal pedal artery, think about vascular insufficiency and think, where did this come from? If they have difficulty with peroneus strength, think about what is more proximal. If there is diffuse tenderness and you are unaware what could be the cause of this, think about capsular disruption, and think about a multiligamentous knee injury. And think about an obese patient even with a low fall, or just stepping off the curb or doing something like that. So be aware, because if you're not aware, sometimes it ends in about 15 to 20% of the people with vascular injury. It ends in an upper leg amputation. This is a disastrous outcome for an injury that we could have treated properly. And it's not only the short-term outcome that is important, it's also the long-term outcome if you look at the increased risk for osteoarthritis for this patient population. Sometimes you see it happen. If you look at professional football, for instance, even there it happens. You see this player who last season got a push and has a distortion of his right knee. You see from the side and the yell that the patient has that there is probably a patellar dislocation, but there's more than just that. So when you go to the patient, you examine the patient. This was in COVID time, so there were no spectators, which made it even more of a bigger impact. Hearing the scream of agony of this patient, you can examine the patient. You can then, after examination, I already felt that there was a medial collateral ligament injury, there was ACL injury. You try to stabilize it, reposition it, and then treat it after that. And this is something, if you're aware of that, in this first instance, you can already notice this, and you already know that you have to do more than just reposition the kneecap. This patient then goes through a whole cascade of steps. This is a poster that we've made where you can see the patient in the green area where they start off in a journey. They go through time where they've had an injury, and the green path shows that they talk to the people around them, they get information. They can then go to the hospital where they can get a full diagnosis, and then they go through a treatment options, which is sometimes operatively or sometimes non-operatively, and sometimes there are more steps operatively, and then there is a rehabilitation period that they have to go through, which can go with bumps and ups and downs, and you have to try to get them through there and help them through there with help of the physiotherapist, with help maybe of the family around or the sports physician. What we do is based on what you see below, on the societal knowledge that we have. We gain that through research, and with this knowledge we try to sort of put this together for this individual patient. And to do this well, you need to know what the anatomy is, and that is the yellow line that you see above there. So this is a path you go through, and this is a path that we need a lot of assistance with. So if there is vascular injury, we need a vascular surgeon. If there are skin problems or there's neuropraxia or neuromesis, we need the plastic surgeon, and for the multi-trauma patient, we need the trauma surgeon. So it's a multidisciplinary approach, and we are always 24/7 available for that approach in our trauma center. But not only for the acute onset do we need help, we also need that for the recognition, but also afterwards. So we need dedicated physiotherapy, we sometimes need ergotherapy, we need a dietitian, we need sometimes a psychologist, and we need to rehabilitate this patient. We need to gain a lot more knowledge for this, so we also need researchers, we have a prospective registration, and all of these facets are important to get a better outcome for this patient population. So what do? You treat first what kills first. You do what ATLS has taught us throughout the years. If the knee is dislocated, you recognize it just with slight traction, reduce it. If it's irreducible, which I will show later, then you have to open it, do that in a center where you can treat the extra additional surgery that is needed for the ligaments, and do a complete neurovascular exam. So I would suggest for everybody after any dislocation, do a C2 angio and treat this in a multidisciplinary team. I will go into some of these facets a little bit more now. So if you see this puckering where you see the knee, think about it, because if you look at it, the skin is attached to the capsule and it's inside. And if you move this knee, you can't reposition it. You see the posterior draw test, which is positive. The anterior draw test is positive. And if you try to, with valgus and varus stress, the puckering doesn't go away, and you see how lax this knee is. So this knee has more than just injury of the ligaments, it's also dislocated, and the capsule together with the skin is into the joint, and you can't reposition this otherwise than open. So reduce it. You see that the testing is important, so you can do more or less immediately at your accident and emergency department. You can, even in a patient who is awake, collateral testing is not that painful, especially if it's a grade 3 injury. The Lachman is possible. If other tests, if it's not possible to get 90 degrees of flexion and it's difficult to do an anterior posterior draw test, do that later on, maybe in surgery. Posterior sag test is helpful, and if possible, try to know what kind of rotational instability you have. So this physical exam really guides my treatment, and it helps if we know as soon as possible what's wrong. So when you have the patient in theatre, you can test. You see here that in varus testing there is lateral compartment instability, and you see on the left knee that in valgus there is instability. So this is a patient who has bilateral dislocation. It also has anterior and posterior insufficiency. So testing really is, for me, the main key in recognizing this problem and knowing what to treat. But the patient has possibly more injuries, so you have to do a vascular exam. You have to exclude if there is a rupture, specifically the popliteal artery, an incomplete tear, or even an intimal tear. So inspect, look at the color, look at temperature, look at capillary refill, feel pulses, and take an ankle brachial index. And I would really emphasize, if possible, add a CT angiography. We've had a number of cases where this was not done or not done timely, with extra problems for the vascular surgeon and even loss of limb. So the CT angiogram is very clear. Here you see CT where you see a definite stop of the popliteal artery, and this is an acute problem. This has to be treated even before we stabilize the knee. Reduce the knee, maybe the stenosis or the occlusion is then open again, and then see if it really is. But this is an acute problem that we have to solve within hours and not within days. On top of that, the patients, especially if there is a varus trauma and there is lateral damage, neurological examination is vital. So test the tibial nerve and the peroneal nerve. If it is damaged and you have loss of strength or sensation loss, explore it within 2 weeks is what the AAOS recommends. And if during surgery it is obstructed, liberated, and if ruptured, grafted. If it's intact, which in most cases, if I look back at our 200 plus explorations, we only had 2 of these that were disrupted, and one of them was disrupted because of exploration in another center first. The sad thing is that the recovery is poor, and in these cases you have to discuss tendon transfer secondarily. On top of that, radiological examination is very helpful. This can objectify the position, this can objectify if there are fractures. The knee MRI can tell exactly where the ligament rupture has occurred. Is it proximal? Is it distal? This helps in planning your surgical further treatment, and the CTA as mentioned. In chronic cases, it's helpful to know what alignment is, so a long leg axis is helpful. And sometimes you are unclear, is it more anterior, posterior, or medial or lateral, because you don't exactly know where the middle point is anymore, and then stress testing is helpful. Okay, to show that in a case, an X-ray of a patient who came in. On the left, you see that the tibia is not really positioned really in line with the femur. On the right side, you don't really see that it's dislocated. You see 2 extracortical fixations because this patient had ACL reconstruction in the past. It's in place, but it's unstable. It was put in a plaster cast. An MRI was performed, and then you see on the MRI that there is a dark structure which comes from the tibia, which is, it could be, for instance, the medial collateral ligament, but in this case, it was the hamstring, and it was one of these patients who had puckering, and in that way a dislocated condyle through the capsule next to the hamstrings, and you have to reposition it. So this is an indication for surgery on short term. And what do we try to do? We try to restore the anatomy of the native ligament, of all the native ligaments that are injured, try to restore their normal insertion site anatomy, just as we try with ACL surgery, and we try to restore then a normal tensioning pattern and have eventually normal function, and try to prevent as much as possible secondary lesions. This is, of course, not easy. I think one of the examples that we do well is what you see on the right, an eminence fracture where you can reposition the ACL, and I think maybe in the acute setting we can do that. We can restore anatomy in that way, and a lot of cases we know out of reviews that reconstruction or additional reconstruction helps the outcome. So if you look at this patient where it's more clear that the tibia and the femur are dislocated, you see that the tibia is dislocated anteriorly, you think, oh, well, this is a clear surgical case. There is not that much evidence, sadly enough. No RCTs have been performed for multi-ligament injury. This is something that I think we have to pick up, probably not only nationally but internationally. So I think we have to work together with different centers throughout Europe or throughout the world to see how we can best treat this. We know through RCT that an isolated ACL injury, and we showed that in this publication in the British Medical Journal earlier this year, that 50% of the patients can do well if you look at their patient-reported outcome without surgery. I think that this is highly unlikely for this multi-ligamentous group. So this is true for an isolated injury, but for a multi-ligamentous injury, I think we have to be a lot more active and probably invasive to deal with this. Invasiveness can have different shapes and forms, as I showed before, and I think one of the things that you have to do first, and if you treat them in another center, is that you have to make sure that the vascular status is perfect, and that it stays in position. So this is a patient that was operated on for the arterial insufficiency in another hospital. The knee was unstable. They performed a stabilization through this external fixator, which I think at that time was the best treatment, but it really makes the secondary treatment a lot more difficult. It makes it a lot more difficult because sometimes these external fixators are not compatible for MRI imaging, so you're unclear where the exact injury is, and it's difficult or impossible to test. You have to turn down the external fixator before you can really test this knee. And where the pins are placed, it sometimes makes reconstruction more difficult because you can have pin tract infections. So these pins, in this case, were positioned where I would put the incision for my ACL and PCL reconstruction, and you have a higher chance of secondary infection. So I would treat this in 2-stage, take off the external fixator, treat the collateral ligaments, and then go on. There are a lot of different ways of treating all of these injuries, and if you look at a different surgical technique, and this is from a review that was performed just for lateral ligament injuries, you see there are lots of different techniques with different reconstruction patterns, and I think you need to be aware of what is possible and what you are capable of and what you have experience with. So you can go sometimes for more simple reconstructions where you just do a sling technique like this Larsen or Arciero technique, where you use a graft to reconstruct a lateral collateral ligament. I think this is for isolated injury laterally a good thing, and if you have a lot of damage, or maybe you can regenerate or reinsert your lateral collateral ligament, this is a really good technique. And sometimes you need to take care of rotational injury more, and then you have to add maybe the techniques that Laprade has shown us, where you reconstruct a popliteal tendon and make it more or less a popliteal ligament. So it's really important to be aware of different techniques, and it's really important to be aware of personal shape. We know that people are different in shape, in size, and we see that in the anatomy, especially in this acute setting. You really see that there is not a standard setting. We have been trying to find out more about that, and this is a CT image where we've marked in this patient where the lateral collateral ligament insertion on the femur is. You can see where the popliteus tendon inserts, and we are really looking at individual differences. We can and add all of this data, and we've done that in our research project on a statistical shape model, where you've generalized the shape and then you can pinpoint exactly where all of these different insertion sites are. And through this, you can learn more about the variance that there is, and also know what are your important landmarks for this. So this helps me in my reconstruction, and we are much more aware now of variance and what are key points to reconstruct and to exactly reconstruct anatomy again. I would like to end this presentation with a case. This was sent to me. This image was sent to me through WhatsApp, and this was a CT that was made from a patient who had a scooter accident. The CT angiography was made, and what you can see is that there is a dislocation of the tibia versus the femur. You can see that the patella is fractured. It's very communities. And if you look from the back, you can see, thankfully, that the artery is intact, but you can even see some osseous fragments posteriorly. So some of the patella fragments were dislocated. And if you look further at this, on MRI imaging, you can also see the dislocation of the femoral condyles. You can see that the tibia cannot go back to its normal position distal of the femur. And if you test this knee, you notice there is a gross posterior instability. Normally we grade this from 0 to 3, but because the extension deficit, because of the patella fracture, I think this is probably a grade 4. We can stabilize this. This was an open procedure because we had to also stabilize the patella fracture. And after you've done that, you have immediate satisfaction that you see that the instability is gone. Of course, the main thing is now it has to heal, it has to rehabilitate, and now the real hard work starts for the multidisciplinary group, but also for the patient. So I would like to end by reassuring us that we have to be aware, we have to recognize, and we have to know why we need to know all of these things, because we have to treat accordingly. And it's not just a rupture, it's a life-changing event. So I think it's rare, it's a devastating injury. It's maybe not as rare as we believe, because I think they are quite often missed, and we should treat them with an experienced team, and we need to learn so much more about this. So centralizing is a good option, and contemplate referral if you have problems for this. We have started for that not only in our trauma center, but we are working together with a rehab center, and we have a center for complex knee instability, so you can look at our website later to get more information. So thank you very much, and I would hope that you've enjoyed the podcast, and I think it's wonderful that you've been listening. Thank you.
Thank you for listening to this episode in collaboration with the Erasmus Medical Center. We also would like to extend our gratitude to our speaker, Dr. Duncan Meuffels, for this very insightful presentation. If you would like to know more about us, please visit our website at www.physioglobal.nl or follow us on Facebook, Twitter, LinkedIn or Instagram. If you would like to know more about the Center of Complex Knee Instability, visit their website at www.ccki.nl. Thank you for listening.
Was du nicht auch mal hier? Oder